to welcome our first speaker, my friend and colleague, Lissa Tallman. She is the Executive Vice President of Research, Modeling, and Analytics for OptiBrand RX, and she'll be speaking on merging streams of research towards a holistic solution. So welcome, Lissa.
Hi, everyone. Can everyone hear me? Okay, great. All right, there's no clock in this room, so when I'm looking at my phone, I'm just trying to see what time it is, make sure I don't go over. Thank you very much, Jesse, for that introduction. And today I'm going to be talking about merging streams of research and talking about how different streams of research can better inform our communication strategy, right? Because as brand leaders, as companies, you want to be able to communicate the most important aspects of your brands to healthcare professionals and to patients, right, in order to increase the use and adoption of those brands. So one of the things I'm going to talk about today is going to be a case study to sort of go through some of the different ways that we can think about that kind of communication. Oops. Green button, right, guys? Green button. Ah, okay. I want to, for the next speaker, there's 2 green buttons. All right. Okay, so when we're thinking about multiple streams of research, we're a primary market research agency, as Jesse mentioned, so our favorite stream of research is obviously primary market research, right? We want to go out and talk to physicians, patients, other stakeholders in order to learn, what's most interesting to them about the brands that we're representing. We could do that qualitatively, we could do that quantitatively, we could do it with, focus groups, we could do lots of different things. But in addition to that primary market research, there's other streams of research that can help inform the performance of a brand and inform what the best communication strategy is in order to reach those doctors, patients, nurses, caseworkers, pharmacists, whatever audiences that you need to reach in order to increase uptake of your product. And so some of those things are secondary data. I think most of you have secondary data that you're using from larger companies that accumulate those data, like Ipsos or IQVIA. Most of you have internal client data about brand performance, sales, Salesforce outreach, detailing, that sort of thing. And then there's also geospatial data, which is something I think that we think about a little bit less commonly, but can be really important. Geography, whether somebody is in an urban, suburban, or rural area, can affect the way that they receive messages. Also, area of the country, whether or not you're on the East Coast, West Coast. I'm in Canada, so whether or not you're in one of these sort of Ontario versus Manitoba, for instance. I'm from the United States, so if you're from California versus the Midwest, can make a big difference in the ways that messages are received. So you can use information from all these different sources, merge them together in order to discover what are some of the key leverage points to communicate about your brands. I want to talk about a case study, and I want to keep this very anonymous, so I'm not going to tell you what the product is, and I'm not going to tell you what the indication is, but I think it still has a lot of things that I can talk about that are interesting and important. So the first thing is that the product in question here is a product that's third to market. So if you happen to be in a situation where your product is first to market and you're not using that as a piece that you're communicating to doctors, I would recommend that you change your strategy because first to market is something that is a huge advantage because you have time on your side. We hear all the time, doctors who have been using a product longer are less likely to switch to another product. That's first thing. But secondly, in research that we've done, where there's multiple products on the market and the doctor hasn't used any of them, okay? And we say, all right, I know you haven't used any of these products, but given what you've learned, which would you choose? They say, I'll choose product A. And I say, why? And they say, oh, well, I've heard a lot about it. I know colleagues that have used it. It's been around a while. They're not saying it's because it's first to market, but it's because it's first to market, okay? So first to market is a huge advantage. This product I'm going to talk about is third to market, okay? So they're in sort of a disadvantageous position here because they're not even the second one, they're the third one. It's the same mechanism of action as the first two products as well. The next thing is that the product I'm going to talk about does not have differentiation in terms of efficacy. When it comes to efficacy, I think if your product has efficacy and you're not messaging that, that's also a mistake. Because if you give a physician a list of messages, and one of them is an efficacy message, I will guarantee you that's going to be the most motivating, the most resonating, the most preferred message, right? That's what the physicians are looking for. First, they're looking for efficacy. So if you've got efficacy, if you've got a statistically significant improvement in efficacy, then that should be where your messaging goes for, what your messaging should go for. This product has undifferentiated efficacy. It's at parity with these other two products in the market, but it does have better tolerability and safety profile. And I think that's a really interesting one because a lot of physicians say that tolerability is really important to them. So if you ask them straight out, what's the most important things? What do you look for when you're prescribing something? They're gonna say, oh, I want the most efficacious product, but then the second thing they're gonna say is I want the most tolerable product. But when it comes to actually changing prescriptions, those messages of tolerability don't necessarily motivate every physician equally, okay? So some physicians are truly motivated by tolerability, but a lot of physicians, they say they're motivated by it, but it doesn't really actually seem to change their prescribing behavior. Now, if you're communicating to patients, that tolerability becomes a really important piece. Because as a patient, if you tell a patient, well, you could have drug A or B, they both work the same, but drug B is safer and has less side effects, they're gonna choose B every time, right? Like that tolerability is something that's really important to communicate to patients in order to educate them about the products on the marketplace. But for doctors, it becomes a little less, it's less motivating. Now, if you survey nurses and caseworkers, they find the tolerability pieces more motivating as well because they spend more time with patients. I think that's really what it comes down to. A lot of doctors don't spend a lot of time with patients, so they're not hearing necessarily complaints about side effects, adverse events. Depending on the indication you're talking about, like for instance in dermatology, we found that the average appointment after the first appointment is only 7 minutes long, so with your doctor. Even something like oncology, after those first couple appointments, it averages about 20 minutes. That's not a long time with your doctor. Patients are spending significantly longer with nurses, and the nurses and caseworkers are much more motivated by these messages of tolerability, but they're not necessarily the ones making the prescribing decisions. So our product does have a benefit, and I wanna say, if I needed a product in this space, I would choose my client's product. And I don't say that about all the products we have worked on. There are definitely some where I think to myself, something happens to me, don't give me this, okay? But in this case, I really do like the product. And then, so they've entered this marketplace, essentially, where they do have a benefit, but there's just substantial loyalty to the products that have come before it. So the question is, of course the goal in general is to increase uptake of this product in the physician population. We also want to understand, though, they had some secondary data that some physicians had converted to prescribing their product. Okay, so we're looking at the secondary data, and they found that there's this group of physicians that have converted to prescribing their product. So the question was, what was their motivation? The hope was, of course, that there's something about the way that they communicated the unique benefits of this product to this segment of doctors that they had bought in, okay? So the question was, how can we leverage that to communicate that same benefit to all doctors and get more doctors bought in, right? So we want to understand, what was it that was done that motivated them to switch from a product they were comfortable with to this new product? So we wanted to look at this in a number of different ways. So obviously, one option is that it has something to do with messaging about the current product, right? So we spend a lot of time and energy developing the right message, the elevator pitch, what's the right flow of messages, what's the right leave behind, right? So maybe it's something about the product and the way that they've communicated the unique benefits of the product that's motivated at least some doctors. But we also thought, maybe it's appealing to a certain segment of doctors. Maybe what's happening is it's sort of a synergy between these two things, that a particular segment of doctors is more sympathetic to this product for some reason. So then the question is, how can we replicate that thing, right, in other doctors? Or maybe there's something about the institution. Maybe it's a pathway thing. Maybe it's written in their electronic health record, so it becomes easier for them to prescribe, doesn't take as many steps, so that's the reason why they're prescribing it more. So we want to understand what's the confluence of these variables that's creating this high prescribing segment? How can we use that information to craft a communication strategy that converts more doctors into that high prescribing segment? So the first thing we did is we want to look at some of the geospatial data. And like I said, I think this is something that's not leveraged as much, but I think it's a really nice first step. It doesn't cost a lot. A lot of the information is pretty freely available in terms of census. This was a US project, so imagine Canada there. So we want to know, all right, here's our highest prescribers. Where are they located? Are they located in clusters? Are they located clustered around particular centers of excellence? Is there some pattern? Is there some geospatial pattern that we can point to that could be influencing this prescribing? And the answer seemed to be that, okay, yes. It did seem like there were some regions that showed higher prescribing compared to others. And we did this, of course, also comparing like the density of the population. So if you keep population density even, correct for that, it does seem like there are some differences here based on geography. But it didn't correlate to particular institution types. This particular product can be prescribed by a couple of different specialties. It didn't really correlate to specialty. So we're kind of thinking, what is it that's driving these clusters of prescribing? So we had some idea that maybe there's a spatial component to the data, but we didn't really understand why. So then we took this to the primary market research. So we did a series of qualitative interviews, and we looked at 3 different HCP segments. So we looked at high prescribers, moderate prescribers, and low prescribers. We used the secondary data to do NPI match in order to recruit based on the secondary data. So we knew going in, we kept it anonymous with the clients, of course, but we knew going in that we had high prescribing physicians, moderate prescribing physicians who had converted some of their patients to this new product, and then non-prescribers who were not bought in. They were not converting anyone to this. So we want to understand, how are these different groups receiving these messages? So here's our different groups, right? So in terms of the high prescribers, we found them to be a remarkably homogeneous group. In general, they had a trialist mindset. This is probably not super surprising to anybody. They generally said they were early adopters of products. They like to try new things. They like to try to find solutions for their patients, okay? They were at larger institutions. But what happened here, though, is the question is then what supports this mindset? What allows physicians to have a trialist mindset? Because I think a lot of doctors, when they get into the medical profession, they're interested in learning new things, trying new therapies. So what supports this, go back. So, what supports this trialist mindset? And what supports a trialist mindset is essentially having more time, okay? So they were at larger institutions with more support staff, okay? And because they had more support staff, it increased their bandwidth to trial treatments because they weren't the ones who dealt with things like insurance issues. Their support staff did that. They're not the ones who are navigating these different pathways. Their support staff, the support staff is ordering things to specialty pharmacies. The support staff is calling insurance companies. They didn't have to do any of that themselves. So that gave them the bandwidth to think about trialing new treatments. The other thing is that they had, in general, higher patient volumes, so they had more opportunities to trial new treatments. So they, if you have 10 patients, you have a treatment that you're comfortable with, you start with one patient, right? I'll try it on one patient, see how it goes. You have a good experience? Okay, I'll try it on the next patient. And then slowly but surely you start converting all your patients over there. And that can happen faster because you have a larger patient volume coming through your office. If you don't have that many patients, then you don't have as many opportunities to trial something new. So yes, they had this mindset that made them more sympathetic to a more superior tolerability. You know, they were willing to, okay, same efficacy, let me try it in a patient, see if I get less complaints, see if everything is better. So they already had that mindset, but they have the institutional support behind them to essentially bolster and allow for that mindset to become a reality. So essentially in this group, the messages about the product itself, those tolerability messages, were getting through, okay? They chose this product because of its tolerability, and they had the institutional support behind it in order to make that desire to try it a reality. So that was actually pretty easy. The non-prescribers were also pretty easy. They're another group, interesting group, also remarkably homogeneous. We found that they had been practiced longer. They had really small practices. Sometimes they saw as few as 5 patients in this indication. They were mostly community doctors, and they are very algorithmic treaters. We talked to them and they said, I like what I know, and I know what I like. I've been using this for 5 years. Why would I make a switch? I haven't heard any complaints. I personally haven't experienced any adverse events with this product that I have loyalty to. I have no motivation to switch. And in fact, a lot of them said, I don't even buy that this is more tolerable than the product I'm currently using because I and my patients haven't experienced that. So they're putting a high premium on their own experience rather than, clinical trial data, which is going to show you, the percentage of patients that had adverse events, the percentage of patients that stayed on therapy for a certain number of months. They're putting the premium on their own experience. I haven't experienced that, so I have no motivation to switch. The truth is, the client decided, and we suggested, that these doctors aren't really worth a lot of effort in terms of communication because they're not getting a lot of patient volume, so you're not going to get a lot of prescriptions from them, and they're not buying your messages about your product. So don't give up on them, but maybe focus on non-personal promotional communication with these doctors, right? Send them some emails so that they have the information if they want to give it a try, but maybe this isn't where your sales force should be the most active because they are not in practices they don't have a trialist mindset, and they're not in a practice that would support them to become trialists. The most interesting group was really the moderate prescribers, because the moderate prescribers, they buy into the promise of the product. We talked to them and they said, yes, I believe that this is a superior product. It has superior tolerability. I have tried it and I like it. But I don't prescribe it very often. They say, why? Why don't you tried it and you like it, why don't you prescribe it, And they said, because it's really hard for me to prescribe it to my patients because I can't get covered by insurance and they don't qualify for patient support programs. So, okay, we said, okay, what have the sales reps? What has the sales reps told you about that? Oh, we never see reps. So I was like, oh, okay, so you never see reps, so has any rep walked you through, how to get it covered? No. Have reps walked you through the patient support programs? No. We see reps from these other companies, but the reps for your company, they don't come to my office. They don't deliver me these messages about these sort of non-clinical factors. So the way that they were making their decisions about who to prescribe to, they were using socioeconomic status essentially as a barometer. So if they had a patient who could afford the treatment, or if they had a patient who was very low income and was very easy to enroll in patient support programs, they would prescribe our product because it was easy for them to do so. But if they had patients that fell into that gap, they made too much, at least in their minds, for the patient support programs, and too little to be able to pay for out of pocket, they would prescribe something else that they had more experience with that was easier to get covered. They had reps in their office holding their hands. What was especially interesting is that a couple of those moderate prescribers who prescribed to more patients, who were kind of on the borderline between that high and moderate prescriber group, said, oh yeah, I don't have as much trouble getting covered. I was like, oh, okay. Do you see reps from this company? They said, yes. They come to our office all the time. They talk to us about how to manage these things. So I thought, okay, all right. I think we're coming to kind of an idea about what's going on here. And so it seemed like there was a dimension that we really weren't thinking about, and it had to do with sort of patient factors, socioeconomic status, and essentially knowledge of the support programs that was affecting the way that these moderate prescribers, who truly had bought the messages, they bought into the promise of the product. They were happy to tell us, your product is superior, but I still don't prescribe it because of these factors. So then, we went back to the geospatial data. So we saw these clusters. So what is happening? So it's like, okay, we look at places where prescribing is higher, and it correlated with either suburban areas with a above average median income for the area, so a higher socioeconomic class in that direct region around the hospital, or urban areas that had a mix of very high and very low socioeconomic patients. So it totally matched the story that we were being told by the doctors. The areas of lower median income were in general correlated to this moderate prescribing group. We're taking the non-prescribers out of this. These moderate prescribers, they seem to be in these sort of more middle-class socioeconomic areas. So that matched what they were saying, essentially, about their prescribing behavior. Now, there were still some pockets, though, that puzzled us, because there were some pockets where it looked like they still had high prescribing in these more moderate income areas, and we had heard from a couple of doctors in those areas in our qualitative interviews. And we thought, gosh, those are the doctors who talked about seeing the sales force. So then we got the sales force data from the company. So we got that institutional data, and we put it on top of all of this. And it turns out that their sales force was more active in some areas of the country. So we looked at the number of calls and visits by sales region. So we divided up, we used the company's sales regions, we divided that up. We looked at points of contact, calls, so it's a lot of data, and we looked to see what the coverage was, the ratio of sales calls versus the population in that particular area. Because of course, like in a large urban area, the sales calls are higher because there's more people there, right? So we corrected for the population of that particular area, and we found that in these areas with lower socioeconomic status, but still high prescribing, they correlated with areas where the sales force was making more calls per physician than in other areas. So those doctors were having more points of contact with the sales force. They were hearing the messages more. And that sales force, the company investigated, and they found that sales force, was doing things like helping doctors with prior auths, doing things to make it easier, educating them about these patient support programs, showing them how to get their patients enrolled in these kinds of support programs. So they were communicating non-clinical factors to the doctors that were increasing the prescribing. So with all those different streams of research, we kind of came to a conclusion. We wanted it maybe to be we wanted the answer to be some intrinsic property of the product. But in reality, it was really about how the sales force was communicating messages about how to prescribe the product. That was really what was affecting the patterns of prescribing of this product that was third to market. All right, so what did they do? A lot of times we walk away and say, okay, here's your answer. Let us know when you have more work. But we have a longstanding relationship with this client, so we were able to see how our work was sort of implemented. And so the client took that, and they implemented some new Salesforce techniques, more points of contact, shorter points of contact. So instead of trying to book time, for one longer session, said they do more sessions, shorter sessions. And that's actually what doctors want. We asked them for a different client in a recent interview, how long do you spend with your sales force when they come to your office? And we heard answers ranging from 5 minutes to 15 minutes. Nobody said more than 15 minutes, though. Average turned out to be something like 9 minutes. So that's not a lot of time to deliver a whole set of messages, right? So more frequent points of contact in order to deliver short snippets and keep your product top of mind seems to be something that's working. Change the outreach strategy to make sure that sales reps are highlighting the ways. I mean, from an insurance standpoint, they were at parity in terms of coverage, but the doctors didn't know that, and they didn't know how to navigate the system. So changes to the outreach strategy with the sales force to help them understand how to navigate the insurance system in order to get their product covered. And then they based some of these on these regions that were more active and have been most successful. We still do research on this product. About a year and a half later, it's really interesting because product use has increased. There's a lot of things that have happened. I'd like to think it's all of us, of course, but there's a lot of things that have happened, right? But product has increased across the board, particularly in those high and moderate users. We're hearing more about our clients' product when we do qualitative interviews. We're seeing more allocation of share in surveys. So it seems like it's working, right? They changed their strategy. There's nothing about the product that has changed. Their messaging even has not changed. Their website has not changed. Nothing has changed except for the frequency and the way that the sales force communicates these non-clinical factors to their doctors. So, what have we learned that can be extrapolated past this? So one stream of research, it doesn't tell the whole story, right? You need multiple streams of research sometimes in order to figure out what is the right insight, what's the right message. A lot of that can be leveraged at a relatively low cost. This wasn't a super expensive project. They already had the secondary data. They already had the institutional data. We already had the geospatial data. So it's really just 15 qualitative interviews. So there was a lot of value derived from this from a corporate standpoint for not a lot of input, for not a lot of cost. Adding the secondary data doesn't really increase the timeline very much. So you can do this kind of merging at a relatively sleek timeline. I know time is often of the essence, so you don't necessarily have to increase your timeline like you would if you added more primary market research. And then, the other thing is that no doctor said to us, I don't prescribe this because I'm in a lower socioeconomic status area. Like, no doctor's gonna say that to us. But that's the reality of what's happening. So sometimes when you only use primary market research, doctors are telling you these things, right? But by using multiple streams of research, you can start to make some inferences about what's really happening once you triangulate all these different forms of data.